I was fortunate enough to be asked to be the keynote speaker, so I gave the noon keynote, and then I was fortunate also to be on a panel with Corey OBarr and Vendel Washington, and it was a lot of Q&A between us and the audience.
What was your sort of a summary of your message from the speaking that you did?
Yeah, the message is really focused on the biggest driver of death and cost in the United States healthcare today, which is chronic disease, and how we need to re-engineer our healthcare system to be able to tackle it both effectively and cost efficiently. And we presented our own data demonstrating that we can do this. It's something that we can do. We can solve the biggest epidemic of our generation, which is chronic disease, in a very cost-efficient and safe way.
Why is it important for businesses to engage in the healthcare dialogue, and how can their involvement help improve the healthcare system?
I think it's important for business to be engaged because it's the health of their employees, that their employees are their workforce. We know that a healthier employee is sick less, is more engaged in the workplace, has less absenteeism, more presenteeism when at work, is more productive. So it's a win-win proposition for employers to want employees to be extremely healthy. And there are subtle ways that are not that costly that they can do that. So it's working together to figure out how we can improve the health of the population, not only of the general public, but also the workforce.
I now have the pleasure of introducing our keynote speaker for lunch, Dr. Richard Milani of the Ochsner Health System, who will share his thoughts, as I said this morning, on innovation and improving outcomes. I don't know about you, but I'm a little intimidated by these intro slides here. But before I introduce Dr. Milani, I wanted to follow up on one theme from my comments this morning. I mentioned that if we really want to change the healthcare system in a manner that addresses the four themes that are problematic: access, cost, quality, and experience, that it was going to take those of us in healthcare to work together in a fundamentally different way. And I specifically referenced that you would be hearing a little bit more about how insurers or providers are going to collaborate together to address these issues. So in that context, I'm pleased to tell you that you are the first to hear of an announcement that will be made public next week, but want to share it with you today, that Blue Cross and Blue Shield of Louisiana and the Ochsner Health System are launching a new partnership specifically aimed at improving quality healthcare experiences for individuals and businesses in Louisiana while controlling healthcare costs. And you may say, well, I've heard this before. What's different about this partnership? Well, what's different and unique about this partnership is that really for the first time in our long relationship, as insurer and provider, we are going to be fully aligned to implement a shared vision around what it takes to improve the healthcare system across the state. And we both understand that transforming healthcare is really the only way to achieve the results that we need. An initial component of this partnership is going to be a new and revitalized product that will come into the market in 2018 that you will be able to hear about this fall. It is called Blue Connect. And what it will do is provide members in the Blue Connect product with a coordinated, focused care solution through a preferred access to the Ochsner Healthcare System and its partners. And what these members will have is not just access to the Ochsner network of primary care physicians, specialists, hospitals, labs, and other healthcare providers, but that care experience is going to, and you'll hear some of this in Dr. Milani's comments, it's going to include innovations in healthcare delivery. So these members will get access to same-day appointments, to telehealth services, to concierge-type access to care to help them navigate the healthcare system, and a focus on managing their illnesses in a way that keeps them healthy and at home where they really belong to be. The other unique part about this is that both organizations are going to share in the governance and have joint responsibility, not just for traditionally what we've both done, but we are going to collectively look at the financial performance, the market strategy, the product design, how clinical care is being delivered through the delivery system. And for those of you that may have heard Sumesh Nigam at his breakout session, we're going to begin to share data in an open and transparent way that, quite candidly, insurers and providers have not yet done in the marketplace, so that we'll be able to enrich the information on both sides of the equation. And what we think this will do is produce a product and an experience for people that is better and more affordable. And I think these are the kinds of partnerships that we need to engage in, again, as I said, to really transform the healthcare system. So I'm excited to announce that, and I think it's a good prelude to what you're going to hear from Dr. Milani. So let me tell you a little bit about our speaker. Dr. Milani currently serves as the Chief Clinical Transformation Officer and Vice Chairman of the Department of Cardiology at Ochsner Health System, and he's also a Professor of Medicine at the Ochsner Clinical School, the University of Queensland School of Medicine here in New Orleans. His background and research focus is on population health, but he has a special interest in chronic disease and medical informatics. He serves as the medical director of the Innovation Center at Ochsner, which is an innovation accelerator that is really a separate entity within Ochsner to drive clinical innovation. After he received his internal medicine training at the University of Florida, Dr. Milani completed fellowships in critical care medicine at the University of Florida, and also in preventive medicine and clinical epidemiology at Harvard University. And he also is in the clinical disease area through the Ochsner Clinic Foundation. He's authored over 500 publications. He's a frequent lecturer to both healthcare systems and Fortune 500 companies. And he's also the author of an upcoming book, Death and Dollars, Solving the Epidemic of Chronic Disease. So we spent a good portion of our team, yesterday with Ochsner, doing a deep dive on our partnership and working with Dr. Milani, and I'm sure you'll enjoy his comments. So Dr. Milani, welcome.
Thanks a million. Okay. Thank you and welcome. These are honestly not my pictures. They're coming live from Cupertino, but I'll get back to where we are. I can tell you, as part of Ochsner, we're very excited about this partnership. It really will align us in the same direction, the goal of which is to improve health outcomes, and it's something that I know Blue Cross, as well as Ochsner, and of course all delivery systems are interested in, and I think it really affords us opportunities to do things that without each other, well, we couldn't do any other way, so we're very excited. I'm going to start off with sort of our guiding principles, if you will. And this is not the guiding principles for just Ochsner. I mean, this is sort of a national, even international focus. And it's what's been called, for many of you, if you're not aware of it, called the quadruple aim. And this is true for all healthcare systems. And that is, we have to do a better job of improving the experience of care. And that includes quality, safety, and satisfaction. The health of the population. You know, I can do so many things to put a Band-Aid on things or even, you know, replace something, but at the end of the day, I'd like to leave a legacy where the population's healthier than where I started, and that's not always the case. Cost of health care has got unaffordable. We have to do our best to reduce the cost of care, and finally, there is a phenomenon that's getting made the cover of Time and a variety of other news publications about physician burnout and even caregiver burnout. We have to do a way to make the life of the caregiver easier and less complicated than it is today. So let me give you a pop quiz. I'm going to show you the 6 biggest economies based on GDP across the world, and here's what they are. And this is via the World Bank. So the US, followed by China, Japan, Germany, UK, and France. And this is their economic product, their GDP each year, and you see how they rank. Now, the quiz I gave to you is, if the United States healthcare system, if you carve that out and you made that a country, where would it rank? And let me show you where it would rank. It'd be 5th. We'd actually be bigger than the United Kingdom and France in terms of our size. And I can tell you, it's nothing wrong with big, but it's too big. It's 17.2% of our gross domestic product. It's about double all these other countries. We cannot afford the cost of healthcare today. We have to do a way of making us more efficient. That's why this kind of partnership that we're talking about today is exactly what's needed to be able to help fix healthcare. Now, of the 3.2 million, 2.75 of that, 86% of that, is one thing. That one thing is a grouping, but it's chronic disease. So that is the elephant in the room. We could talk about a million things today, but if we really want to do something to impact the health of the population, to reduce costs, improve quality, that's where the money's at. That's where it's at. So it's 86% of the dollars, it's 75% of the deaths. I mean, that is the elephant in the room. It's the #1 cause of disability, and unfortunately, statistically, half of us in this room have one. And for any of us over 65 out there, then there's a 90% chance you're going to have a chronic disease. So it's an epidemic, and we ought to be addressing this epidemic. Moreover, it's not going anywhere. This is the projections for chronic disease going forward to 2025, and it's a problem that we're not facing today well, and it's not going away. It's getting bigger and bigger and stronger. Why? This is what the World Health Organization and the Centers for Disease Control tell us why we have such an epidemic. And it's primarily, not 100%, but it's primarily due to these 4 what are called health behaviors. So lack of physical activity, poor nutrition, tobacco use, and excess alcohol consumption, and the top 2 of which lead to an epidemic that we have today where 1/3 of Americans are obese or overweight. And that leads to a whole host of conditions by itself, of chronic conditions. So how do we manage chronic disease today? I don't care if you live in Singapore or in Japan or in New Orleans or Baton Rouge, anywhere else, and it's really 2 fundamental silos. There's the medications that can best treat it, so it doesn't matter, let's say you're a diabetic or you have heart failure or you have whatever it is, and there are guidelines that say, okay, the most up-to-date guidelines based on the current science says your best chance of survival, your best chance of staying out of the hospital, your best chance of doing well in life is going to be on these. And the only other thing we can do is trying to improve health behaviors, trying to improve lifestyle, and they have a very profound effect. And then finally, the 3rd arm is this: we survey. So I need to get you back to make sure that you're in bounds, you're not out of bounds. And there's nothing else. There's not a 4th or a 5th out there. So how well do we do? Let's look at the first one. How well as a nation do we get you on the right therapy for a chronic disease? And the answer is we score an F. It's less than a 50% chance today that if you go anywhere, Seattle, Boston, New York, California, less than a 50% chance that you'll be on the current best evidence-based care for that chronic condition. If you have heart failure, it's less than 30% chance, wherever you go. So are we doing a good job of making sure you're on the best medications possible to keep you out of the hospital, to keep you alive, to keep you well? And the answer is no. How about part 2? How well do we do in behavior? Well, this is data from the Google Food team and the Yale Center for Consumer Insights that tell us that wellness initiatives fail most often because they rely on placing too much emphasis on providing information. That's what we do in healthcare. We provide information. Evidence from behavioral economics has shown that information rarely succeeds in changing behavior or building new habits or food choices. Behavior often changes from intentions. So the point being is that we're not in med school, in pharmacy school, in PA school, in nursing school, we're not trained in behavior change. We say it's important to change behavior, but we're not trained in the science of behavior change. And if you want to know who is, there's 2 groups of people that are. If you're the honest truth, it's Madison Avenue, because they're getting you to buy their Cokes or eat their Doritos or whatever it is that they're selling you, and it's Las Vegas. And it works. Las Vegas gets you to gamble more. Then everything's a science there. This is not by luck. And that's true science of behavior change. And those are the true experts in getting to us to do things that we might not otherwise think about. Finally, the 3rd thing. So we don't do a good job in behavior change. We do a horrible job in getting you on the right medicines. And then finally, surveillance. If you have uncontrolled hypertension as an example, the average person in the United States today, 92% of which will have health insurance, will see their doctor 4 times a year, and they still leave with uncontrolled hypertension. So we don't do a good job even in the surveillance aspect. So if you look at the 3 sort of arms here, and it's not, when I say we, I'm saying not only just the US, I'm saying Europe, Asia, across the globe. These are the ways we manage chronic disease. So why? How did we get this way? Are we intentionally trying to not do a good job? And the answer is, of course not. We've got great people in healthcare. But why do we fail? And here's why. Well, first, this is a survey of physicians in the U.S. that tell us, this is tough. Why are we doing so bad? Because it's tough, it's complex. I don't have enough information. I don't know what's going on when they're not here, in between visits. It's a tough thing, it's very complex. If you lived in 1990, the average man lived to a life of 46 years and a woman of 48. That was the life expectancy for a man and woman in the United States today in 1990. And how did they die? They died primarily of acute conditions. About 60% of the top 10 causes of death were all acute in nature. And we built our healthcare systems and delivery systems on the backbone of this. So if we were all on a spaceship and we were all going to go to another alien culture, and we're the experts in healthcare, and they said, listen, design a healthcare system around, for us, the first question that all of us would ask would be this: what do you aliens, how do you die? What are you sick from? And then we'd work backwards. So if we are having acute conditions, we'd build hospitals, we'd have emergency rooms, we'd have clinics, we'd have a waiting room. You come in, I break your arm, I fix it, you come back, and it's all good. But how are we dying today? This is 2010. The average male lives to an average life in 2010 of 76, and a female of 81. 97% of the top 10 causes of death are chronic conditions. But we're living in an acute care system model of delivery. So managing patients today, we need continuous data. How am I possibly going to manage a condition that's changing daily or weekly by collecting 3 or 4 data points in a year? Imagine running a business. Let's say we're selling pens or shoes, and we have sales all over the nation. You're going to check your books and your sales figures 4 times a year, and you're going to win? There's no way. You'd be out of business in no time. Somebody else would be eating your lunch. I'd be shifting supplies over here, moving things over here. I'd be checking multiple times a day. But we collect data on our humans and our patients with conditions that change daily or weekly 2 or 3 times a year, and then we expect it to work. The second thing we have to know about is this, and that is, in healthcare, we're used to what's the information collected within the healthcare system. And how much of that does that contribute to your health? So as a human being, your healthcare system, for the life of your life, will be responsible for about 10% of your odds of doing well or not doing well, influencing your health. What about the other 90%? Well, environmental exposure is responsible for 20% of the deaths across the globe. That's 5% of your lifetime risk. And believe it or not, you're saying, well, I don't live in a country that's got this problem. I hate to tell you, but you do. So even within our own country, we have issues related. I can show you how ER visits, hospitalizations are directly related in many cities in the United States to particulate matter. So environmental exposure is there. Social circumstances, it's bigger than the healthcare sector. It's 15%. So 15% of your life and your health outcomes will be determined by social circumstances. We'll talk about it. 30% is your genetics, and finally the biggest piece of the pie of all is behaviors. 40% is behaviors. So what about social circumstances? About 28% of people 65 and above live alone. And you go, so what? If you live alone and you're over 65, your odds of a heart attack or stroke go up by 30%. Just living alone. And God forbid you're a woman over 75, because almost half of them live alone. And just that feature, just the fact that you're living alone, increases your heart attack and stroke risk, and that's other conditions too, which I'm not getting into, just that alone by 30%. All other factors controlled for. There's a lot of reasons why. Here's data. This is looking at emotional support based on a variety of stressors. No stressors, 1 stressor, 2 stressor, 3 stressors and during life. So moving is a stressor. Changing jobs is a stressor. Getting a divorce, having a family, loved one die. These are all life stressors. And this is death, mortality on the y-axis. Now look at the one on the right. If I have a high emotional support, it's completely flat. The point being is that we are animals, we are humans, and we're social animals, and we depend on our other humans for support. This is interesting cutaway. in our hospital wing, if you have heart failure, we give you an iPad, and you go through a variety of survey data, and you can watch some educational videos about the importance of diet, and sodium is one of the things that can put you into heart failure. And if you score out high on sodium consumption, we ask 2 additional questions. Number 1, does anybody but you buy your food, does your grocery shopping, and does anybody but you prepare your food, cook the food? And I can tell you right now, I mean, my wife does shop and she loves to cook, and I'm pretty lucky because of it. So I'd have to answer yes to both. If I answer yes to either one of those, it asks me a 3rd question. Would you mind putting down that person's email address? We would like to send them a video and just say you have a salt-sensitive condition. We're not going to say anything more about it, so that they can watch a little video about, the importance of low-sodium foods for you. And then everybody says, sure, yeah, here you go, boom. Here's the data. The bad news is that only 1/4 of the people will open the email. So we've got to do a better job of sending messages that'll get you to open the email. But if you watch the video, if that other person, no matter who they are, watch the video, that person's chance of being readmitted back to the hospital drops 43%. They watched a video. And the chances of that person ending up in a hospital drops by 43%. Now why? And there's one reason, that's the obvious reason, is now maybe they're cooking using low sodium foods. And I think that's a part of the reason. But I think the bigger reason, honestly, is because that person's now activated. That person's now interested in you. That person's want to say, you know what, not only am I doing this for the low sodium food, but you got to make sure you take your meds, and you got to make sure to make that appointment. They get activated in other areas. You've invited them into your life in a way that's going to support you. That's social network. How about behavior? There's a lot of people, you can't change anybody's behavior. Does it have any effect at all? Well, this is what the World Health Organization tells us. Taking your medicines is a behavior. We call it medication adherence. That's a $100 billion a year problem across the planet. What the World Health Organization tells us is that increasing the effectiveness of adherence interventions may have a far greater impact on the health of the population than any improvement in anything else you do. Go make a new robot, make a new stent, make a new thing. It's okay, you might help some people, but this will have a much greater impact. If you could just get people to take what we know works, hopefully we're getting them on the right stuff. That's another problem, but if I can get you on the right stuff, if I get you to take it, it really does work. So here's what happens to adherence if you have a chronic condition, if you're a diabetic, if you have heart failure, if you have high blood pressure, high cholesterol. Within 10 months, less than half the people are taking their medicines as directed. That's a big opportunity if we could just get people to do the right thing, but they're not. Now, why? Well, there's a thing if you have a chronic condition that we call, and it's in the literature, called patient activation. And all it means is this. Are you feel like you're part of the team? Let's say I'm a diabetic. The way I should look at it is that my doctors and nurses and care team are working with me, and we're going to conquer this thing. We're going to be on top of this, and I'm going to control it, and we're working together as partners. Just like Blue Cross now is going to do the same thing in terms of a delivery system like Ochsner. We're going to work together as partners because the goal is that's north. We want to control this thing. Or am I passive and saying, well, I don't really know what's going on. The doctors kind of know, and maybe whatever they say. Well, the bad way is the disengaged and overwhelmed is level 1, but as I move along this continuum, I'm going to level 3 and level 4, and you go, okay, so what? So now you're engaged and you feel like you're part of the team. Who cares? Well, this is what happens about taking your meds. So it doesn't matter what the condition is, whether you have heart disease or diabetes. If I go from level 1 and 2, which are the low conditions in the yellow, up to the ones to the right, I'm taking my meds. And we already know if I do that, good things happen. These are the bad things that happen in healthcare. So if I'm more activated in gray, I'm half as likely to get readmitted to the hospital. I'm half as likely to experience a medical error or have poor coordination. So the kind of things that we'd want for ourselves and our loved ones are going to happen if I can get them more activated. And it costs less. The people that are more activated, it costs less to care for them, and guess why? Because they don't have to go in the hospital as much. They're not having as many bad events, so guess what? It doesn't cost as much to care, to pay for their care. So it's keeping our costs down. Does changing behavior change outcomes? Well, this is 50 years, from 1960 to 2010, on public health. So we've improved smoking cessation, and we've added an extra 1.25 years to every human being in the United States as a result of our smoking cessation on average. Automobile safety has improved. We've added another almost half a year. But we've lost ground on obesity and poisonings, so we netted out about a half a year on public health measures of life expectancy on average to every person in the United States today. This is the single best study that I love to show about behavior change. This was a study done in patients that were basically on the border of becoming diabetic. They're metabolic syndrome patients, and this is a diabetic prevention study. So the idea is this. If I do nothing, I know this person has a high likelihood the next, say, months or so, or maybe year or so, of becoming fully diabetic. They're not there yet, but they're kind of inching up. What if I gave them a drug, an oral drug, which is still the best oral drug available for diabetes today, called metformin, or not? And the answer is the metformin prevented them from crossing into diabetes better than nothing. But look what the best thing was. Lifestyle change. If I got them, even though I don't know how I can change behavior yet, because we haven't been taught that yet, but if I can get them to eat right, to exercise, to do the right thing, it knocks the daylights out of a medication. Not that you can't do both, but it's still the best thing possible. So we don't want to shortchange this other arm of behavior change. That it works. It's just that we've got to do a better job in healthcare of getting people to do it. Shame on us. We need to do better. So this is the classic way we encourage behavior change. I've got an obese doctor telling his obese patient he's obese. Lose weight. And pretty much that doesn't work. Not that we shouldn't tell them to lose weight, but the point is if you just rely on that alone, it's probably not going to work. It turns out that for all of you out there, the things that impact you the most in terms of whatever it is that you do, health-wise or otherwise, you're heavily influenced by your friends and family, the people you come in contact with on a regular basis. One person in your friend group starts doing something, good or bad, and it picks up. And it travels, if you watch this across populations, literally like an infection across the population. It travels the same way. Health, good or bad, health behaviors. Can timely support change behaviors? Yeah, it turns out it's shocking. If you had asked me years ago, hey, we're going to try this, do you think it's going to work? And I go, hey, you got to try it to find out, but I don't think it would. Well, it does. Texting. But not just any kind of texting, what we call a semi-personal text. What's a semi-personal text? You can send me a message, a text that says, I want you to do this, this, this. But if it said, my first name is Richard. If you said, Richard, I want you to do this, 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 it has a great effect. So it's a computer that's sending out a text and periodically just addressing you by your first name, and it cut your smoking cessation rates in half. I mean, in other words, you're twice as likely to quit smoking than not. And it was just that simple program that you can write, and we use that, by the way. This is other things, not just smoking. This is LDL cholesterol, blood pressure, body mass index, which is obesity, exercise activity, and smoking. This is a study done in Australia and New Zealand, just using these semi-personal text messages with a little message. It works. Now, it's not the only thing you'll ever do, but my point is, it costs us nothing. It costs us a few minutes of programming time, and then bingo, out it goes. Pennies. What else changes behavior? Well, whether I like this or not, this is survey data. This is what the public is telling us. And they're telling us that mobile apps, many of them, not all of them, have the capacity to change my behavior. Not just change them, but change them in a good way. It changed the way I manage or think about my health and well-being, and moreover, it positively impacted my health and well-being. And it doesn't matter whether it's food and diet tracking or exercise, nutrition, any of these kind of things, sleep. So the public is telling us that these things can be effective for them in terms of modifying their life. Physicians feel the same way. They feel that apps have that potential. There's plenty of bad apps out there. We're not saying all apps do, but there are good ones, and the ones that are good have that potential. This is 2,000 patients with a chronic condition. And they were given the option of filling a prescription that their doctor gave them for a medicine, or getting an app based on a recommendation by their doctor. And you can see that 90% of them would prefer the app than a pill. So the public wants this. So the question is how? I got all these apps out there, all these devices. How can I get this all to work? So we decided to steal an idea from the Apple Genius Bar and created at Ochsner a thing called the OBarr. We actually have several of these now. And this is basically a service to the public. We have curated apps that we know that patients have told us they love and that we know as subject matter experts are good. And we've got them loaded on iPads, and they can sit down and play for free, and we can have a genius, quote unquote, behind the bar that can help assist them. And we also sell connected devices. It could be a wireless glucometer, or a wireless blood pressure cuff or whatever, that we can, if the patient wants this, that data can come right into the EMR, so it's waiting for them whenever they see their doctor. They don't have to write logs anymore or do any of that stuff. It just automatically enters in. And moreover, if you're, and I'm going to pick on old people, if you're an old person that may not be tech savvy, no problem. We'll do it all for you. Just give me your smartphone, blah, blah, we'll do it. We'll show you how to use it so that there's no barrier to entry. You can participate in all this regardless of age or tech savviness. We even create our own prescription pad on the left. You don't need a prescription pad, but we have this in our primary care offices so they can send them down the OBarr and say, you know what, there's going to be a good app for you to do this. You might want to give that a shot. Or we can get you a connected device that'll feed this information directly. So, if we're developing a digital platform for chronic disease, how could we change these issues? I've given you the burning platform. The burning platform is one, it's epidemic. Number two, we're not doing a good job and no culture is across the planet. And the reason we don't do a good job is that we're not getting on the right medications and we don't even know how to get people to change their behavior. And we're not surveilling you enough. I mean, there's a lot of ways where we're failing. This is the risks leading to death in Western society today. And the biggest single risk factor leading to death across Western society is high blood pressure. It's 10% of the entire global healthcare spend. Think about that. The entire cost of healthcare for the entire planet, 10% of that is related to only one condition. It's high blood pressure. 1/3 of the adults in the United States have high blood pressure, 1/3. And only half are under control. So think about that again. 1/3 of the adults in the US have high blood pressure and only 50% are under control. But there's a difference if you live in Louisiana. Because if you live in Louisiana, it's not 1/3 of the adults, it's 40% of the adults. Half are under control and half are not. But 40% of the adults in Louisiana, Mississippi, Alabama, and West Virginia, the 4 biggest states, have high blood pressure. And what I'm showing you is a heat map, basically, of deaths related to hypertension, and we are ground zero in the Gulf South. This is it. I mean, this is the worst place in terms of death rates related to a condition that is eminently treatable. It is treatable. It's fixable. This is not one that you have to have any problems from. If you look at basically 2000 to 2013, hypertension deaths went up 23%. All other causes of death, including murder, anything you want, automobile accidents, cancer, dropped over that time period, and hypertension is the only one that went up. There's a fallacy that some healthcare systems are not immune to, they believe in, that somehow an office measurement is the only measurement that's going to be meaningful. And this is a call to action by the American Society of Hypertension and the American Heart Association, that's what the AHA and ASH stand for, to say, no, that's not true. The current technology is accurate, reliable, easy to use, inexpensive. Home blood pressure monitoring is actually better predictive of stroke and heart attack and end organ damage than is office measurements. So it's a better predictor of cardiovascular risk, it's more reproducible, and it actually, believe it or not, improves medication adherence, which is a nice fringe benefit. So if you had the choice between the two, you'd take them all, but if you only had to pick one, you take the home. Home is actually the more accurate data, not the stuff in the office, as long as you're using a decent unit. And now they're plentiful. So we were the first in actually the world to integrate patient-generated health data into the medical record, and we developed a relationship with Apple because they created this thing called HealthKit, and so it got a lot of press for us. But this is sort of our blueprint for how we see fixing this problem. Remember we talked about all the issues that exist? Fixing the problem is first we need more data, which is on the upper left-hand quarter. We can't manage a disease that's changing daily or weekly by collecting 3 or 4 data points in a year. We have to get more data. It's got to go through an algorithm, an analytics engine, and then go to a specialized center, we call it an IPU, Integrated Practice Unit, where we can get you on the right meds, change the meds, work on your lifestyle, work on behavior change, work on patient activation. We send reports out to patients, we send reports out to our doctors, and we can then potentially control this condition. I'll show you a quick little video that actually Apple made that kind of walks you through the process real quickly, and it's a lot easier to see if you could just sort of visualize it, so I'll cue it up now.
The most common chronic disease in the United States is hypertension or high blood pressure. It's about 30% of the adults in the U.S. It's a big problem. If we're going to be successful in managing chronic disease, we need to be getting continuous data from patients so that we can monitor them and course correct. We've created a new program monitoring patients' blood pressure in their home using iPhone and the health app, and we've been able to dramatically improve how many people get under control in a short period of time.
I was diagnosed with borderline hypertension about 25 years ago. They call it a silent disease because you don't feel anything. And it was a complete surprise to me. I had no idea what it was or what it meant. So I went to enroll in this hypertension monitoring program.
Hi, Andreas. How are you?
How are you?
It starts with a series of questionnaires that tell us a little bit about their physical activity levels, their sodium consumption, other factors that play a role in high blood pressure. The next step is we give them what we call a prescription, although it's really tongue-in-cheek prescription, to go to the OBarr, which is a wonderful place where patients can look at apps on an iPad that might be beneficial to them and get technology set up from a healthcare perspective.
The OBarr helped me set up the Bluetooth blood pressure cuff, synchronize it to the health app on my iPhone, and then also my Apple Watch.
Then we enable MyChart to allow the data to come back seamlessly directly into our EMR, our electronic medical record system.
It'll come to us, all the information.
Before, it was the occasional visit to the doctor, and then it was kind of disheartening not knowing what happened between that time when you visited the doctor and the next visit. Now, my health information is available to my physician on almost a daily basis.
Hi, Mr. Rubiano.
Back at the hospital, we've created a dashboard to display the patient-generated health data in a user-friendly way for the care team to be able to act accordingly. They're able to communicate with patients on a real-time basis, provide feedback to them, as well as reports to the physician.
This program has made me very aware of the things that are important for my health. Now that I have this ability to visualize what's going on with my activities, my blood pressure, my heart rate, with my weight even, I am able to do things about it. That's quite empowering.
Using iOS, using Apple Watch, using Health app, we've had a dramatic effect on health outcomes in patients with high blood pressure, and we see this extending to all forms of chronic disease going forward, like COPD, asthma, diabetes, high cholesterol, even arthritis. We think this is transformative. It's much more powerful than just any single drug that we can prescribe.
So we've developed this relationship with Apple by virtue of HealthKit, and they produce this video and so forth, but it does describe a little bit how the OBarr integrates with the whole program. It's 100% virtual. The data does come in time, real time, and analytics are performed and stratifies these patients. We collect a lot of information, including social determinants, which are very important in predicting outcomes. On the front end, we phenotype each individual, and then we target that phenotype in terms of how we manage them. Our focus is to not only get the blood pressure under control, but also do that other thing we talked about. I want to improve their patient activation, and there's a science to that. If I can get their activation up, all the boats go up, okay? And they take their meds, good things happen. Patients get a monthly report, not a newsletter. It shows exactly their progress and additional things they can do. And remember we talked about the texting? Yeah, we do that too. And we use semi-personal texting just like those other studies do, and it does work. 43% or so of patients want medication reminders real time, and so we can program that into their smart device. And these are our outcomes. So if you look at sodium consumption, we can drop that within 6 months. It continues to fall even beyond that, but I'm just showing you 6 months data. This is blood pressure control. And what you see here is the following. These are people that were all enrolled that had been out of control for more than a year, so that means there were 0% control rates. The gray area is seeing their physician, so they're doing a good job. And then our program is in blue, and ours continue to rise. And then that drop in the gray area, that is expected. And in fact, it drops further if I take it out farther. And the answer is why? And here's why. We've been at a 50% control rate for this disease process for more than 3 decades. You go, well, I don't get it. How is it 50% control rate in 1980 and it's still 50% control rate in 2017? And the reason is this, and that is doctors are getting people under control. But people that are that are under control today, about the same number fall out of control as those falling into control. So the bottom line is that I'm doing good here and then I lose them over here. And then I'm trying to do good here and then I lose them over here. So I'm never getting above 50. Our program, we're actually able to capture this and prevent people from falling out of control. So they never get out of the boat. They're able to monitor this over their life. They love the program. The satisfaction rates are very, very high. And moreover, we talked about the other goal being activation, and we do statistically improve activation levels. So activation means that all adherence goes up and good things happen. These are CG CAP scores, which, as you know, is a government survey, and they tell us that before and after, they find that their overall and mental health dramatically improves. And moreover, if you were to sort of to extrapolate to population, then if I were to take the 50% that's out of control and move them into a program like this, then this is what you could conceivably occur within even a 90-day period, not the end game, just even 90 days. Using our data, that would suggest that you'd have easily in 90 days that kind of control. People want virtual care. They want it because it's convenient. And I'll tell you, everything in your life is more convenient. You want a restaurant reservation, you go on Open Table, and you don't have to make 20 calls. You find out this one's available, and I like that one, we'll book it. And it's convenient. You know, you're in another town, you call Uber or Lyft. It's convenient. You're not going through a lot of steps. And so people are looking for convenience in healthcare, and so they choose virtual care for convenience. And in fact, that trumps about every other message we could provide to them. Even saying, we can prevent a heart attack or stroke. Well, that's kind of nice, but what I really like is convenience, is what they're telling us. And in fact, that's the cover of our brochure. So our concept is this, and that is, the idea is we want to get you on the right medications for whatever condition you are, and we have pharmacists that do that. They're following the guidelines with no variation. And then we have health coaches that work on the patient activation, the lifestyle, the sodium, the diet, the exercise, all those things, and they work together. Moreover, this gets even more efficient by adding more disease states. So as we add COPD and diabetes and other programs, our efficiency actually improves, because now multiple things start intersecting. We can actually get more efficient and more cost effective. We were very fortunate that the ONC took notice, the Office of the National Coordinator, and they actually feature us in their patient engagement playbook, which is online, as a program that engages patients, and we all know that that's part of the equation of solving the crisis we have in healthcare. And then we were also very fortunate that there was an innovation contest with Harvard Medical School and Harvard Business School, and we were very fortunate to be named as a finalist in that as well this year for the work that we're doing in sort of re-engineering how we manage chronic disease care. In fact, I left this morning with a group that flew in from Japan. They were actually in Cupertino, and then they flew here. And they came to New Orleans for only one reason: to see how to do this. They want to bring this capability back to Japan. And we've had visitors from Europe, Southeast Asia, from around the US, to help learn about new ways of delivering care that is both economical and creating high quality at high levels of satisfaction, which meets that quadruple aim that we talked about. Finally, this is where I think our next step, what we're working on now, and that is a digital assistant. You know, we talk about layers. You know, you see your doctor X number of times per year, and then we have this layer that we just created that's a lot more interactions that are occurring more frequently. What about a layer that's even below that, where it could be almost a daily interaction? And that's where things like Alexa and Siri, these chatbots, have a great opportunity. So we're working with a company now in working on a chatbot for diabetes. And the experience that we've seen thus far is that even people that have been diabetic for more than a decade, still some of them have fundamental questions like, what is insulin, or how do I draw it up right? And they're afraid to ask their healthcare provider. They're embarrassed by acting it, but they're not afraid to ask a bot. So we've created our own movies, and you can see that, you know, can you show me the best way to draw up insulin? And we can say, sure. You can answer right now, and let me pull up a video.
Step 4,
and
use an alcohol wipe.
The point is that it can then pop up a video that shows them exactly what they need to do in the correct way. And they don't have to feel bad about that, and that's something that's with them at all times. So that's sort of the next step forward for us as we create yet another layer that's cost-effective and scalable across many populations. So I'll just summarize here. I'll stop here and just say, look, there's great opportunities. Typically, health systems think about the delivery of services, and they operate in this small slice of the pie. We have an opportunity to take in the whole pie and dramatically impact outcomes, and we think we can do that cost effectively using technology, using behavior science, and working collaboratively with payer organizations like Blue Cross and so that we're aligned in the same direction. Excuse me. So thank you very much for having me today, and I hope the rest of your session works out well. Thank you.
Our ability to do things is getting better. We can achieve better quality care than we have today at a lower cost using technology and using behavior science.